Thank you very much, Madam Chairman, and I'd like to thank the local organising committee for inviting me to speak. So when Vinna contacted me and asked me to speak about critical incidents in cardiopulmonary bypass, I sort of felt like it was a little critical incident myself, really. I don't have any disclosures around talking about anything about bypass. But I thought the first thing we'd do is look at a definition of a critical incident. And it's an episode of care. It doesn't always have to be a dramatic event. And it's an incident which certainly some of the ones that occurred in my practice have had an impact on me thinking, reflecting about what I should do in the future, how we might change things. And over a consultant career of now 20 years of doing cardiac surgery and actually working in cardiac operating rooms for about 25 years. I've had a fair number of incidents that involve bypass and involve pre-bypass and post-bypass. And I think I was talking to Actual beforehand, and anybody who says they haven't just probably hasn't done enough, or maybe they're much better than I am. Might be one case. But I think if a critical incident happens, it's something that may change your view of how things occur. And ones that occur on bypass are sometimes a major medical emergency. They can be very unpleasant. They can be pretty rare, is the other thing, although I'll show you some data at the end suggesting they may not be quite as rare as we think. But in your practice, it may be something that you haven't seen very many times. Certainly in the last couple of weeks, last month, we've seen two episodes I will discuss that one I've seen once before and once I've never seen before. To do with going on bypass. Fortunately, it wasn't in my operating room, but I happened to be in the operating block, so I had to go across and help. It often leads to a difficult situation. You need to work as a team closely, and it can be a communication problem. And there is absolutely no doubt that some of the critical instances to doing with bypass are lack of communication and lack of team working. It is absolutely critical in cardiac surgery that you as an anesthesiologist talks and discusses things with your surgeon. They talk and discuss things with you. You tell and discuss things with the perfusionist as they will. Virtually every heparin incident that has occurred is due to the fact that people have failed to follow standard protocols that include a discussion that the heparin's given, the ACT's done, heparin's given, it's safe to go on bypass. You wouldn't believe it happens, but it still happens to this day. Right, so let's think about the timing of when critical incidents can occur. Well, I was trying to think about this a little bit when I was putting this talk together. I was wondering whether there's something that occurs pre-bypass. I think there is. There's a pre-bypass period just before bypass where you can do things that can make a profound event of going on bypass very bad for the patient. There's obviously the period of initiation of bypass. Those are really unpleasant events if things go wrong. And then there's some of the more catastrophic things that occur on bypass that we'll talk about. So pre-bypass, actually it's not so much a critical instance of bypass, it's much more of a critical instance for the patient, because from a patient perspective, probably the most devastating injury that can occur to somebody with successful surgery is to have a cerebrovascular accident, some form of stroke. And the instance of that has a wide, complex etiology. But there's no doubt that aortic palpation, manipulation, cannulation, cross-clamping, all of which are required to do surgery on bypass, may result in a critical incident and a stroke, particularly in a patient that's got atherosclerotic disease. So I've got a little picture here of epiaortic scanning. You can see a very calcified area here and a sort of very friable area here. Now, the surgeon may well be able to feel this, but they may not be able to feel the friable areas. There's been quite a lot of discussion in the literature about the use of epiaortic scanning, whether you should do it or whether you shouldn't do it, and what the benefits towards it would be. And we certainly do it occasionally when they're worried about palpating an aorta. I mean, one could say, well, why not just do it off pump? And I certainly know a lot of surgery in India is done off pump. But when you think about the neurological outcomes from the major RCTs of on-pump and off-pump, there doesn't actually appear to be much difference. The major benefit, as Archer pointed out, is transfusion around off-pump. And if you were to have a surgeon who does a lot of off-pump work, they probably do their distal anastomosis and they can operate on a moving heart quite well. But it's not something that you would want. I wouldn't want a surgeon who doesn't do that very often operating on my coronaries. I'd want my heart absolutely flaccid and still. So coming back to epi-aortic scanning, there have been a number of small studies that originally suggested there might be some benefit in neurological outcome and that you should do this routine practice. And what they were looking at was decreases in transcranial Doppler measures of embolic load that went up to the brain. However, there was one RCT done by George Devani, and that showed very little difference. We'll just have a look at George's study, and it's quite interesting because they randomized 113 patients to epi-aortic scanning or manual palpation. There was a bit of crossover from the manual palpation to the epi-aortic scanning group because the surgeon would feel something there and go, well, we probably ought to scan this, and that was possible to do in the trial. The interesting thing was that surgical management definitely changed. If you do an epi-aortic scanning, you will get surgeons choosing to cannulate somewhere different. And surgical management changed in about 30% of the cases, right? As opposed to 12% of cases when they just manually palpate it. So you'd go, well, that's interesting, I would think this is going to do something. But then you look at the Neacham score. Now, the Neacham score is a score looking at post-operative confusional states. And here you have the score in black for the epi-aortic scanning group and white for the control group, days 1 to 5, and you don't see any difference between the two. So you change your management doing something, but you don't actually change the end event for a patient. And if you look at the NIH stroke scores and you look at the post-operative complications, including stroke, death, extubation time, hospital length of stay, they're all identical. So I think that there is possibly a role for epi-aortic scanning to avoid these sort of critical events around the time of going off bypass, but the evidence for it is pretty slim. Okay, this is a really, really unpleasant event. I don't know if any of you have ever had it. We had one last weekend that one of my colleagues had to deal with, and he certainly found it very stressful. I had one almost 18 years ago, so it's pretty rare to have these. And essentially, it's a malperfusion syndrome that occurs when you go on bypass. The vast majority of the time, it occurs when you're dealing with patients with type A aortic dissections, and you end up perfusing the false lumen. It can occasionally occur when, we've seen it occur a couple of times, when trainees have been cannulating the aorta and the surgical boss isn't around. And you would hope they notice, somebody would notice that they've actually got a massive hematoma at the aortic cannulation site before they say to the perfusionist, let's go on bypass. But you wouldn't believe it, sometimes they've just gone, let's go on bypass. And lo and behold, we've gone on bypass and they can't perfuse anything because the pressure is ridiculously high on the line. You go, no, stop, don't make it, because once you cause that injury, if you start trying to perfuse down it, you're going to create a big false lumen, and God knows where that's going to go. It's going to go into all sorts of different vessels and make it more complicated. If you cause a disruption with an aortic cannula, you might be lucky enough to get away with it without having to do a full repair, but you might not. So how do we tell whether you've got a malperfusion syndrome and acute aortic dissection? Well, if you've got low or differential pressures across your arch, you've got two arterial lines in, assuming that they haven't gone for a femoral approach, then that might be occurred. So differential pressures is a big key. Low pressures in both areas is a big key. But again, that can be quite misleading sometimes, particularly if they've cannulated the right subclavian, because your pressure down in your right radial might just be low because that's the way they've cannulated. High line pressures is a real key. So it's not high line pressure that they've gone on bypass and there's a problem such as a cold agglutinin, or they've got an oxygenator issue. It literally just can't get onto bypass, and that's the big issue. And it was fascinating when I was looking at this. You would think after all this time of doing aortic dissections, over God knows how many years they've been going on, so they would know the optimal place to cannulate the aorta. And interestingly, when I was reading a review article about this, it's actually still remarkably controversial. So let's have a look. So this is a picture of the arterial vascular tree. And the most common area, and I'm afraid I've shown it from the right, but actually it's the left. The most common area is the femoral cannulation. And usually, surgeons will cannulate the right femur. That's because if you get a tear here or somewhere up here and it extends all the way down, it's much more likely to extend down to the left femoral than the right femoral. So most of the time, if they're going to use femoral cannulation, they'll cannulate the right femoral. It's the one case that I had was a malperfusion syndrome with a right femoral cannulation. And it was interesting because we didn't have differential pressures or low pressures in either arm, which is slightly odd. It made me always think afterwards, I wonder whether I might have been in a false track or lumen in one of the radials. And you had the sort of usual small rise in lactate to 3, 4, 5 millimoles as we cooled down and went to a short period of circulatory arrest. But really, it was the continuingly rise of the lactate when we were rewarming, when it went to 10, 12, 15. On rewarming, we're going, oh, this is not good. And then you notice there's no urine output. And then you notice the patient's profoundly acidotic and you're on full bypass and you're going, something's horribly wrong here. And by that time, it's just way, way, way too late. The goose is cooked and gone. You've got somebody who hasn't had any cerebral perfusion for a long period of time, and it's just an utter disaster for everybody in the operating room when you realise you've just spent 6 hours of your life and probably killed somebody, and then for the family, clearly, or the patient, because they're not going to wake up. However, it's not a fail-safe, the femoral route, and the largest observational study that's been come out would suggest that out of 107 patients, 3 had a malperfusion. I've only ever had 1 via the femoral route. So how about the auxiliary and subclavian? Because that seems to, particularly the right subclavian, that seems to be much more common. Certainly a lot of our surgeons seem to have moved to it over the last few years. And I slightly worry about this route of approach because, at least with the femoral, they were always bloody quick getting on bypass. With the right subclavian approach, they take forever. I mean, it's just extraordinary how much longer it takes to get on bypass. And I think part of it's actually quite difficult to find. And one of the areas about it is that you've got to be certain that you haven't dissected, or where the tear is hasn't dissected up the right innominate and taken any area here. And certainly just actually going into that area can cause an intimal flap. We had an incident last weekend, a neurologically mid-70s woman with a type A aortic dissection goes into theatre, 2 arterial lines across here. They go into the right subclavian, and when they put the cannula in, they have a high line pressure, so they go, oh, we must have a problem here. And rather than going somewhere else, the consultant surgeon put a trouser graft onto the right subclavian, perfused into that. Pressures were okay in both arms. They thought that was okay. It turns out in post-mortem, what happens is they've caused a right intimal flap, and it occluded the right carotid artery. And they had a malperfusion syndrome, so they didn't perfuse the brain. I heard all about the NERS machine being used beforehand, and we use NERS routinely in all these sorts of cases. And it's very interesting because the NERS was normal on the right side and low on the left side, which is sort of what you might expect with a right subclavian approach. At the end of the case, the right pupil was fixed and dilated when the lactate was still high, and they finally figured out they hadn't been perfusing correctly. And again, it was just like my case. They hadn't, the pressures were okay across the arch, a bit low but not desperate. But then as they cooled down, the pressures were a little bit differentially odd, but when they rewarmed, they were vastly different. And that's the point in time they realized that they had got a problem, and they actually went into the repaired area and started perfusing properly. But again, it was too late, and the lactates were rising, and the patient unfortunately had brainstem tests 2 days later and passed away. So transapical cannulation. Now, this is, I don't know if any of you have seen a transapical cannulation. It's sporting. It's very sporting to see that done. It requires you as an anesthesiologist to have a reasonable amount of skill, because the tip of the aortic cannula is going to go through here, and you've got to be just above the aortic valve. Otherwise, you trash the aortic valve during the procedure. So there was quite famous heart surgeon in London who's well retired, so I can tell the story. He was one of the first surgeons at St Thomas's who did the first cardiopulmonary bypasses in the late 60s, early 70s, called Mark Bainbridge. And there was something known as the half Bainbridge and the full Bainbridge manoeuvres. And they were to do with the Nelson manoeuvre, which is a wrestling manoeuvre where you strangle somebody. And the half Nelson was well known as you lifted the heart up to look at the grass underneath after cardiopulmonary bypass. And that usually led to a degree of squealing from us as anesthesiologists and a lot of hemodynamic compromise. And the full Bainbridge was they lifted it up and completely twisted it on its end, and that led to complete and utter cardiovascular collapse. And that's the sort of manoeuvre they have to do a transapical approach in what is, a big hematoma area. So I've seen one, and we decided not to do any more after that because it seemed pretty messy. We've done actually another one, to be honest, because we felt it was the only area we could go to. One of the other areas of cannulation that's of interest that's coming up is true lumen cannulation. That's coming out in the literature. I've never seen it done. I'm hoping that I will never see it done before I retire, certainly by any of my surgeons, because they certainly aren't quick enough to do it this way. So you require to have you put a venous line in without an arterial line, and you sort of go on bypass without forward flow. You're just going to exsanguinate the patient. And then you transect the aorta, shove a cannula into what you think is the true lumen, and snare it off. Now, in the report that came out, which I read, 176 cases, the average time was 30 seconds. I can't believe any of the surgeons I work with would be able to do that quickly enough. So I'm rather hoping they don't read this paper or ever choose to do that. So I thought I'd show a modern-day bypass circuit, and they have got complicated when you break it down into a schematic. And when you look at the modern-day micro-computer bypass machines compared to some of the machines that certainly we were using in the late 80s and early 90s, they are amazing bits of kit. And when I first started cardiac anesthesia, one of my older consultants described it as a little bit like a swimming pool, where you drain blood, put it through a heater, and put it back in the pool, and it's warm. Now we have all sorts of areas where you can do all sorts of stupid things. And one of the major areas are the vents and the suction areas here, and that is where I've seen most of the air entrainment. We've had a pulmonary artery vent where they blew rather than sucked. So we now routinely have a checklist in our hospital where you have to put all the suckers into water to make sure that everybody's got it the right way around. But one can see through this componentry a number of areas where disasters can occur. We have had a disaster with blood cardioplegia, where blood cardio of the incorrect dose for a child was delivered to a neonate, resulting in utter disaster. And that was a simple system failure where a machine was set up for a child that didn't come to theatre and nobody changed it. That simple failure of systems and ended up with a disastrous result. One of the areas that is changing is the concept of hyperbaric subatmospheric oxygenation to stop small air bubble entrainment or get rid of it. And this is some work that's come out of the Gibson group. And what they're doing is air entraining on the bench and in animal models now, and measuring embolic loads pre and post oxygenator. And one can see that by denitrizing and by nitrogen absorption, post-filter, you really don't have any gaseous bubbles. And I think we might see this being developed a lot in the future as time goes on. It's quite an interesting technique. Massive air embolism, the only one I've ever seen was the pulmonary artery vent, which they blew loads of air into the heart. It's always due to either an equipment-related problem, a technique-related problem, or a human factor, which is particularly inattention to the reservoir. We've sort of not seen too many of these that say the only one that I've ever seen is that one there. I'm going to end with a couple of things about loss of power. It's reported at about 1 in 15,000. Modern day machines do have batteries, the older machines didn't. And you need to hand crank. Even the battery won't last very long if you're going to use it. Hand cranking, you usually have 1 to 2 or 1 to 3 gearing now, but it's still exhaustive. I've had one case where in a peripheral hospital, we had to hand crank for 35 minutes, just the perfusionist and myself, till they got off bypass, because the power to the machine just went and we couldn't redo it. And it was utterly exhausting to try and get 2.1 to 3 litres per minute squared of flow into a patient. You might think that losing power is a disaster on the bypass machine. We had an entire theatre 3 weeks ago lose its power. The other three theatres in the block all had power. This entire theatre just lost power. We had no idea. Couldn't get it back. Everything went down in the theatre. They're on bypass. And suddenly you've got to think, crikey, did we charge the ventilator battery? No, they hadn't even bothered checking it. So the ventilator wouldn't work. Could they use the lights? No. Could they use electric cautery? No. How could they warm the patient up? No idea. CPB heater wouldn't work. They were cranking at the time. How do you measure the pressure? Nobody could remember where the aneroid tychoses were. And battery-operated infusion pumps are an issue. Now, we actually ran multiple lines, power lines, using extension leads from the two other theatres, all sort of jellied together, because each one was only about 2 meters long, and they had to go about 15 meters, and we got enough power.
Dr. Gill, please sum up.
Yep, to heat the patient and get them off bypass. So my last slide is heparin is often not given. Surprisingly, it's always a communication problem. I'm not going to talk about proteins and agglutinins. And this last slide shows that actually, historically, over a number of papers, we do see oxygenator failures, mechanical failures, and electrical failures, but rarely does it end up in harm if you know how to manage it. Thank you very much.